Let's discuss what the most common objections are and the best ways to address them. Probably the most common objection is the following. If my patient is not having problems with oxygenation during either deep sedation or general anesthesia with propofol, why do I need the supernova? And the answer is as follows. Although your patient's oxygen saturation may be 100%, it doesn't actually mean that they're ventilating just as well. And the reason for that is when we give sedation medications, it causes us to hypoventilate, where our brain tells our body, specifically our lungs, to breathe shallow and rapid. If we can't take a deep breath, that causes our alveoli to collapse and a complication known as atelectasis. Now, it's been well documented that both prevention of atelectasis and the treatment for atelectasis is applying positive pressure, specifically positive pressure ventilation. The supernova will allow the clinician to apply positive pressure ventilation through the nose to help keep the alveoli inflated and potentially prevent atelectasis and its associated postoperative complications such as pneumonia. A second objection that we hear quite often is this. If the patient's upper airway obstructs, I can relieve it with the nasopharyngeal airway. Why then do I need the supernova? Our reply to that is as follows. Yes, you are correct. A nasopharyngeal airway can relieve upper airway obstruction. However, what it cannot do is help prevent and treat the complications associated with atelectasis. Now, it's well documented that when your patient receives sedation medications, it causes atelectasis for the following mechanism. It prevents our brain from telling our lungs to take deep breaths. This is known as hypoventilation. If we can't take a deep breath, our lungs start to collapse. A nasopharyngeal airway cannot apply positive pressure to help keep the alveoli open. However, with the supernova device, it allows for a continuous positive pressure to be delivered to the alveoli, keep the alveoli open, and help prevent the complications associated with atelectasis, such as pneumonia. Here is a third objection that we commonly hear. Why do I need the supernova device for my practice? And our answer is as follows. Every time you give sedation medication, you cause an upper airway obstruction. And it is well documented that upper airway obstruction is the same pathophysiology as obstructive sleep apnea. Now, the treatment for obstructive sleep apnea is continuous positive airway pressure, or nasal CPAP. How often are you actually using nasal CPAP in the operating room? And the answer is probably never. Well, if we know that upper airway obstruction ends up causing atelectasis, our lungs to collapse, why are we not helping to prevent or treat it? And the reason is because it's really not available to us in the operating room. The supernova is a nasal CPAP device that can allow the patient's airway to be stented open to help relieve that upper airway obstruction. Here's another very common objection that you'll hear on nearly every sales call. If the mouth is open, won't the oxygen just leak out of the mouth? And the answer is no. Some will leak out of the mouth, and some will also go into the lungs. The path of least resistance is not an all or nothing phenomenon, where all of the gas will flow towards the path that has the least resistance, and none of the gas will flow towards the path that has the most resistance. Fluid dynamics actually shows that there is a proportional relationship to gas flow and how large the diameter is. For example, if you have a small mouth opening, yet you have a very large diameter trachea, most of the gas will flow towards the trachea while some comes out of the mouth. Now, one way that the supernova compensates for that leak out of the mouth is through its supplemental oxygen port. You can connect the oxygen tubing to the supplemental oxygen port. which will add an additional 15 liters per minute of oxygen. Now, as some of the oxygen leaks out of the mouth, we're compensating by continuously delivering more oxygen to the lungs. The next objection has become much more common recently. What is the difference between high-flow nasal cannula and the supernova? High-flow nasal cannula can deliver continuous oxygen at about 60 liters per minute. What this allows for is passive inflation of oxygen into the lungs, along with apneic oxygenation and apneic ventilation. However, it cannot apply a continuous positive pressure greater than about 7 centimeters of water. Therefore, there are three situations where apneic oxygenation and high-flow nasal cannula would not work. The first are patients that are obese because if they have too much compression atelectasis where the abdominal contents press against the lungs. The second is an upper airway obstruction. It cannot generate a high enough pressures to actually stent open the airway. And the third is if the patient is desaturating. In all three of those situations, the recommendation is to transfer to a positive pressure ventilating device, such as the supernova. The supernova goes on the nose, is a nasal mask, and does two things. The first, it applies positive pressure ventilation by either connected to an anesthesia machine or to a resuscitation bag. Second, through its supplemental oxygen port, it can supply a continuous flow of oxygen up to about 15 liters per minute. So now, not only do you have continuous oxygen going through the supplemental oxygen port to the back of the patient's nasopharynx, but intermittently, because it's also connected to an anesthesia machine, we can apply positive pressure ventilation. Let's move on to the next objection that is commonly seen. Will the view of the airway be blocked? And the response is no. The supernova was specifically designed, as shown here by the location of the anesthesia port, to not obstruct the view of the airway. Typical anesthesia masks, the anesthesia port connects vertically and would obstruct the view. However, the supernova, the anesthesia port, was designed horizontally. So now the clinician can have a direct view into the airway. Here's another commonly asked question. Will nasal ventilation cause gastric inflation and potentially increase the risk of aspiration? Our response is as follows. Nasal ventilation has not yet been studied to determine whether or not it increases the risk of gastric inflation and aspiration. However, what has been studied is it's been compared to a full face mask. They compared the peak airway pressures of a nasal mask for nasal ventilation to a full face mask with full face mask ventilation. What they showed was that nasal ventilation was associated with lower peak airway pressures, on average 17, compared to a full face mask which had peak airway pressures of about 25. So theoretically, nasal ventilation should lower the risk of gastric insufflation since the peak airway pressures were lower. Anecdotally, what we're also seeing is that the mouth can act as its own pressure relief valve, where once the pressure inside the airway starts to get too high, you'll start to have some gas leak out of the mouth, which will help keep the pressures low. Is nasal ventilation effective on patients that are completely anesthetized? Here's our response. In 2013, Mass General did a head-to-head study where they compared full face mask ventilation using a full mask versus nasal ventilation using just a nasal mask in completely anesthetized patients. And what they found was that nasal ventilation was in fact superior when compared to full face mask ventilation, where nasal ventilation group was associated with lower peak airway pressures and higher flow rates. The supernova has also been successfully used in hospitals on patients that are both fully anesthetized and completely paralyzed. How does the supernova's seal compare to the seal of an inflatable anesthesia mask? Underneath our nose, there's a small space. That inflated balloon is very thick and it has the potential to block the nostrils and therefore block any oxygen going into the nasal pharynx. The supernova seal, as shown here, is very thin, even on the inside. That way, when it rests just below the nares, it doesn't have the potential to block any oxygen getting into the nasal pharynx. Here's another commonly asked question. Why would you want to ventilate a morbidly obese patient who's already at risk of aspiration during laryngoscopy and intubation? Our response is as follows. The current recommendation is to pre-oxygenate morbidly obese patients with positive pressure. And the reason is because the risk of desaturation is so high. Therefore, with the supernova, not only will you pre-oxygenate with continuous positive pressure ventilation, but you'll keep that mask on throughout the intubation. Now, because the mouth will be open when you're attempting laryngoscopy, any excess pressure will leak out of the mouth rather than go into the abdomen, inflate the stomach, and potentially increase your risk for aspiration. What advantage does the supernova provide over a video laryngoscope? Here's our response. Although video laryngoscopes have been shown to increase first pass success and potentially decrease overall complications, they cannot maintain a patient's oxygenation and/or ventilation because there's no way to deliver oxygen or positive pressure through a video laryngoscope. The supernova complements a video laryngoscope by allowing us to continuously deliver oxygen and ventilate our patient even while video laryngoscopy is being performed.